not in your leaflet, is a fact I want you to be aware of. In 1982, 3 institutions in the Texas Medical Center joined together. That is the Institute of Spirituality and Health, at that time called the Institute for Religion. The Institute for Religion, Baylor College of Medicine, and Rice University came together to create a Center for Medical Ethics. It was housed on the top floor of a 4-story building that the Institute for Religion had right behind Methodist Hospital. Hurricane Allison took care of that building. Nevertheless, the first director of the Center for Medical Ethics was Baruch Brody. At the time, it was one of the first centers of medical ethics in the United States and was recognized as such. And later, the center moved to Baylor College of Medicine, and Dr. Brody served there until he retired in the last year. He's received many awards. He's presented the Michael DeBakey Research Award from Baylor College of Medicine. In 2007, he was presented with a book that honored a respected person in his field while he's still in his lifetime, and that book was entitled The Pluralistic Causality. Dr. Brody has written extensively in theoretical philosophy and bioethics, has authored dozens of books and chapters and articles in the journals. He's earned several major awards and grants for his scholarly work in philosophy and humanities. And Dr. Brody has provided leadership on committees on such organizations as at NASA, at NIH, and the American Philosophical Association. Please give a warm welcome to Dr. Brody.
Thank you. I'm going to leave this.
And you do not have any relevant financial interest to disclose.
No, I don't, although I've been praying for years that I will eventually get one. Not all prayers are answered. Okay, let me begin by making a sort of a semi-apology. I have very bad allergies, and Houston is not cooperating this spring. So there will be a number of occasions, I hope fewer, but I never can tell, when I will suddenly need to stop and cough a little bit. Please just understand that happens in a city when tree pollen count is now off the top of the chart. Okay, I have 3 objectives to do today. One, let me say a word back before I turn to the official title of this talk is, Can We Afford Health Care at the End of Life? And the brief answer to that question is going to be, health care at the end of life is no different than all types of other health care, and it's not clear which one we can afford and which we can't afford. And people are making a great mistake to think we should focus in on health care at the end of life. So it's sort of a challenge to the question. I'm going to begin by identifying the nature of the cost crisis faced by healthcare in general and end-of-life care in particular. I'm going to evaluate various proposals for prioritizing forms of healthcare, particularly healthcare at the end of life. And then I want to turn to the important question of the role of the healthcare professional in dealing with this crisis, and more generally, the role of the healthcare professional in taking care of patients near the end of life. So that's my agenda for this morning. Years ago, I was a seminarian, and I was told that you can't begin a talk without a text for the day. So, okay, here's my text for today. And it's a quotation from Taro Aso, the finance minister of Japan, as reported on page 63 of The Economist for February 23rd. I was preparing this lecture and reading The Economist, and lo and behold, the text I wanted was right there in front of me. It occasionally happens that way. Old people in costly terminal care should be allowed to hurry up and die to ease the burden on an over-indebted space. I'm not quite sure what the over-indebted is. I think it just means Japan is feeling a financial crunch. By the way, he had to take this back because the country rose up in great opposition. Keep in mind the demography of Japan. Japan is an increasingly aging society, and all those old people were not necessarily keen to hurry up and die. Okay. The odd thing about all this was that it was said in Japan, whose healthcare costs are relatively low. In fact, Japan spends only about half of what the United States spends per year, and is one of the lowest among the organized countries in the organization, the OECD, which essentially is an organization that brings together ministers from all the major developed countries. Okay. So I do want to talk, I think I skipped a slide, no. I do want to talk first about this business of the financial crisis. And the main issue to consider is the percentage of gross domestic product devoted to health. That's the main number we need to look about. Gross domestic product simply means everything we produce in the country. Now, I want you to go back for a moment and think about what it was like when you were in training. And you needed to live as well. So you had a bit of a financial problem. And there were three ways you can solve the problem. One, work part-time and earn all the money you need. That didn't usually work out. Secondly, ask your parents to help you, which means you were drawing down upon past. Or third, take a loan, hoping that I'll be able to pay it back in the future. When we look at the percentage of gross domestic product and we look at it's growing, what that really means is that unless we're producing, to pay for everything, we are either selling down our past assets, which is why the United States has been selling so much of its industrial base to investors from other countries, or we borrow against the future until nobody wants to lend us any money. And mostly we get away with that because other countries are even in worse shape. So people, at least for now, are prepared to lend us money. But can't go on forever. That's the lesson that Europe is now learning, and I fear that's the lesson that we will be learning. Why is the percentage of gross domestic product devoted to healthcare such an important issue? There are three reasons why. The first is the reason that the economists talk about when they talk about opportunity costs. If we spend more money on healthcare, it's not available to meet other needs. Everybody has a long list of other things that our country needs. Two of my favorites are improving our infrastructure. Try driving down Main Street at the moment, and I think I'll say nothing further on that topic. And secondly, providing appropriate higher education without excessive student debt. Well, for spending the money on healthcare, we can't spend it on these other things. You can have your own list of things you'd like to, but the important point is what you spend on one place, you can't spend on the other. Secondly, in a strange way, the growth in healthcare expenditures has a very negative impact on employment and salaries. And this is something that perhaps isn't often noted. Employers want to pay a certain amount of money for the labor they hire. They have no particular interest whether it gets given to people in salaries or whether it gets given to people in health insurance that the employer is providing. But you can't get them both because the employer is only prepared to spend a certain amount of money. Therefore, if more money is spent on the health insurance because healthcare costs are going up, there's less money available for the wages. Or alternatively, the employer just says, I can't afford it anymore, and he fires the workers. So this is an important impact that people often forget about. And finally, the impact on international competitiveness. As our healthcare costs go up and the health insurance costs go up, it adds to the prices of goods, and that makes countries with higher healthcare costs, less like the United States, less competitive in the international marketplace. And at this point, I have to quote a second text from Lee Iacocca. Some of you remember who he was. He said, how can I sell my Chryslers when the other countries can sell them for cheaper because they have less healthcare costs. I made the mistake of buying one of his cars one time, and that was the least of his competitive problems. But as a more general point, I agree with this. So we really need to be concerned about how much we spend in healthcare, and particularly how much we spend on healthcare as a percentage of the gross domestic product. Now, if it was just a question of people paying for healthcare out of their own pocket, and there are a few people, not many, who do that, there would be no social issue. You got some money in your pocket, you want to spend it on a doctor, fine, go ahead. But the truth of the matter is that's not how we fund healthcare, because there are very few people who can afford healthcare that way. About 2/3 of the healthcare expenditures are provided either through federal and state expenditures or from employer contributions to worker insurance plans. That means that the cost of healthcare is not a private issue only, it's crucially a social and a societal issue because we're the ones who are paying. Okay, now I'll explain to you why economics is called the dismal science, which is what actually its name has been for a long time, partially because the news is bad, and partially because they got all these numbers. And you sort of get, anyway. Total healthcare expenditures in 2011 came to $2.7 trillion. That's not billion, that is trillion. This comes to just short of 18% of the gross domestic product. That means about 1 out of every $5 in the United States that we've earned, we devote to healthcare. I've always found it hard to understand how the executives of major healthcare organizations say there isn't enough money to provide healthcare when 1 out of every $5, defense is only $500 billion. That pales in significance. The good news is that in the last couple of years, the percentage of gross domestic product devoted to healthcare has not gone up. But the bad news is the explanation. As people lost their jobs and therefore lost their health insurance, or as people who are worried about their economic future, they put off whatever they could, including visits to doctors, hospital care, and so forth. That's why it didn't grow. So it was good in terms of the numbers, but lousy in terms of what it did for people. Just the historical perspective, increases in percentage of gross domestic product were stable from 1993 to 2000. Those were the Clinton years, but that was primarily because the economy was growing very rapidly. When the economy slowed down, but healthcare costs continued to grow, it started going up again, and that's what has eventually produced the 17.9% figure. It's a requirement when you're lecturing on this topic to say we spend much more than the rest of the world. But the truth of the matter is, look it up at the table in front of you. Our nearest competitor are France and Belgium, who spend a little over 11%, going all the way down for the 7th country, being Canada, that spends 10.4%. Remember, Japan was only 8%. So it's not merely that we spend a lot of money and that we spend a lot of our percentage of gross domestic product. We're spending much more than anyone else. And there's no reason however to think that health, as measured by the normal indices, is any better in the United States than in these other countries, all of whom have longer life expectancies. Okay. So what is the right percentage? 20 or so years ago, I was at one of these Baylor programs for Friends of Baylor, and I was speaking there, and also Dr. DeBakey was there, and somehow or another his ride didn't show up. So someone asked me, would I drive him home? I said, privilege. We get into the car, and he says to me, you know, Dr. Brody, that was a good presentation. But you know, 8% is a lot of money, but we're a rich country. We can afford to spend up to 10%. He thought he was being generous. When you think back today about that conversation, I wonder if he would have said the same thing about 18%. So the real question is, what is the right percentage? One thing we know for sure, we aren't going to spend less on healthcare and less of a percentage. So the goal that has been adopted by many is that healthcare expenditures should not grow more rapidly than the country's economy. And for the last 3 years, that has been true. But remember, it's been true because people are foregoing the medical care that they need. It's not going to remain that way, even independently of PACA, Obamacare, but that will certainly contribute to the issue. So here's CMS's projection over the period 2010 to 2020. Average annual healthcare spending growth is anticipated to outpace average annual growth by 1.1 percentage points. That may not mean anything, in a sort of formal way. So the way to understand it is by 2020, we will be spending 19.8% of the gross domestic product. I need to tell you, with all the respect that is properly due to the actuaries at CMS, they usually manage to underestimate when they're doing their projections. Okay. So when people started thinking about this issue, how do we control healthcare costs? An important factor was noted, that healthcare expenditures in our country are concentrated on a small percentage of people. 21.8% is concentrated in 1% of our population. They are the big spenders in a given year. And half of healthcare is spent on only the top 5% of people. So the natural suggestion was, we've got to cut costs for these people on which we're so spending money. And the intuitive thought was, it's got to be the elderly, or it's got to be people who are dying, and especially it's got to be elderly people who are dying. And that's how Minister Sato came to his perspective. The elderly are not promising. Having now been about to celebrate my 70th birthday, I am happy to hear that we are not a promising group for those on whom they should limit health care. Turns out in the United States, we spend about $1,200 more per person per year on the elderly than the younger. So there is a difference, but not a big-time difference. So that leads us to the dying patient. And we've been hearing for some years that we're just spending too much money on these dying patients in unsuccessful attempts to keep them alive. That's why the minister said they got to start dying because we can't afford to keep them going. I'm going to give you 3 arguments as to why that's an illusion. First argument, high cost of dying are not really that high, despite what people say. The cost of caring for patients in the last year of life has consistently run no more than 25% of Medicare costs, and that's the population of which you have most of the dyers, older people and disabled people. But even in Medicare, it's only a quarter. And Medicare is only 20% of our health care. Multiply the two together, 0.25 times 0.20, and you get a relatively small percentage that's spent on elderly people who are dying. So the high costs of dying are really not that high when we look at it as a percentage of healthcare expenditures. And by the way, most of that Medicare money, more than a majority, is not spent on care designed to keep them alive. It's mostly spent on things like, I should have, instead of writing nursing home, I should have put home health, because that's the larger thing for Medicare. And a great deal of it is spent on hospice care. So it's not a high percentage of our healthcare expenditures, and much of it is not spent on futile attempts to keep these patients alive. Much of it is just spent on keeping them sort of comfortable and functional in the process of dying. But there's one final argument about why prioritizing healthcare at the end of life is not a useful strategy in controlling healthcare costs. And the problem is you can't tell in advance who are the patients who will actually die. And I'm going to give you some data now to support that. But before I do that, I need to tell you an anecdote. It's about the first serious consult I ever had in the medical center. And it came from Ben Taleb Hospital, where I was already rounding in the MICU. And at that point, they were not used to taking patients off respirators and allowing them to die. But they had a patient and a family who wanted that to happen, and the healthcare providers sort of thought it was a good idea, but they had never done it before. So we gathered together. Maybe it wasn't a consult, it was a group discussion. And we went back and forth. The patient wanted, the family wanted. Finally, we said, okay, this patient is near death anyway. He doesn't want to struggle anymore. Let's take him off his respirator, give him a little bit of morphine to control his agonal breathing, and let him die. So that's what they did. You know what happened 2 days later? He went home. We were all sure that this man was in the throes of dying. It really is hard to know who's the ones who are going to die. So anecdote doesn't settle questions. Let me tell you about a study I ran with a group of colleagues and was published in Archives of Internal Medicine. We decided to look at MICUs and identify the patients whose care was futile, but on whom we were spending a great deal of money. The thought was, you see, let's prove to society that we're spending so much money on patients who are dying, and there's nothing we can do about it. Then we might decide to prioritize their care. So how do you study such an issue? At that time, there was something called the Apache Score. And the Apache Score was really an attempt to gather a great deal of data on people's physiological abnormalities, hyper or hypo, and produce a number, and then ask how predictive is it of the patient's dying. And the Apache Score, by the way, was highly validated in very large populations because you couldn't get access to the algorithm for developing that score unless you agreed to send the data back on your patients. So it was an ever rapidly growing database. Okay, so we felt we had a really good measurement of how sick a patient was and how likely it would be that they would die. So then we said, let's go into the MICU and see how much money we're spending on those patients. Not much. 1/5 of 1% were spent on the patients whose likelihood was a 90% likelihood of dying. That means people who had just a 10% chance of living were only 1/5 of 1%. Our ICUs were full of sick people, but not ones whose dying we could predict. In fact, as Dr. Neal, who was the resident who did a lot of the data collecting, made the remark, you know the trouble is, by the time they're so sick you can predict they're going to die, they're already dead. And that's actually what our data showed. Now, I know there are some pediatricians here in the room, and they may think it's different in the pediatric ICU. So we did the same study in the pediatric ICU and got basically the same result. So it's not that we're spending that much of a percentage of health care on the dying. And much of what we're spending is comfort care, not to keep them alive. And anyway, we can't tell in advance who they are. So this does not look like a promising place to save money in order to keep healthcare costs under control. Let me go back just for a minute. The truth of the matter is, this type of data came as a shock to me. Because for years I had been talking about the high cost of dying. Everybody else was talking about it. But when you actually look at data, it's a funny thing that happens when you look at data. Sometimes you discover you were wrong. And you got to be prepared to admit that. Okay. Now, knowing that this was the case, and there was still this feeling there were all these futile cases on which they're spending money, I, and together with Dr. Halevi, who was at that time an instructor in the Department of Medicine, led a task force of 40 hospitals in Houston, which developed the so-called Houston citywide futility policy, which was an attempt to say, maybe we don't have the numbers, but with a good group of people, we can figure out who it is that is inappropriate to spend more money on. I'm not going to go into the details now of what the policy was like. The crucial point was it didn't do much good. And it's sort of sad because we spent about 2 years developing the policy. In the 1999 to 2004, over 6 years, 256 patients were the sum total of the patients to whom the futility policy was applied. Only in 178 of those cases did the committee agree with the physician. And the policy gave a 10-day period before we would discontinue the care, and actually a high portion of the patients died. Just remember, you can't tell they're sick enough to be sure that they're dying until they actually die, or very shortly afterwards. Okay, so it was an interesting experiment, and I'm proud of the policy, but it isn't making much of a difference in the provision of health care at the end of life. We got to find ways of saving money. My point until now has not been, oh, we have all this money, we don't need to worry. My point until now has been, there is this money that we're spending. We do need to worry, but stop focusing on the dying. Start focusing on the larger systematic issues, because the dying are not where the money is going to. I've listed here 3 things that I'm particularly interested in. There are many other suggestions. The first is coordination of patient care to avoid duplication, unnecessary readmissions, and so forth. And the electronic medical record was supposed to help us do that, because you didn't need to run the test again if they had been run by another doctor a few weeks earlier. And if only all healthcare providers used an electronic medical record that could talk to each other, then in fact this would save a lot of money. But God bless the United States, the Texas Medical Center, and all these other wonderful things. But in fact, the systems we have adopted don't talk to each other. I now want to make a confession. I get a little bit of my health care, not at any Baylor-related institution. I actually go down the street to UT, to Herman. Now, I know the UT people think that's a great thing. There are others of you, I did apologize. Okay, there's an excellent rheumatologist there, and I need to see her. When I get my doctors at Methodist or Luke's to send medical records to Herman's, they disappear in a black box. Someday, some year, they may or may not show up in my chart. So what I've now done is solve the problem. Every test that is done. I ask the provider to give me the results in writing, and I carry them from one doctor to another. But not many people do this. And actually, I'm not sure why I do it, except it seems to me stupid to waste the money on doing tests again. So recently, this will make the St. Luke's people happy, I had an echocardiogram here, and I picked it up. I got the results, the reading, and I carried it over to UT so that my rheumatologist could see it. And so she didn't need to order an annual echo because I had had it done anyway. And I also took it to my nephrologist because I have kidney problems. And then they don't need to order it. And I just saved society thousands of dollars. I wrote a letter to the president, said, can I have back 1 or 2%? Didn't get a penny. But this is madness. I mean, I'm anal compulsive, so I do this. But this is really madness. Unless we find a way for all the healthcare providers and systems to communicate with each other, we will waste billions on duplicative tests. But there's another problem as well. The truth of the matter is there are many patients that we readmit because we haven't coordinated care between when they were in the hospital and afterwards. You know, you walk out of the hospital and you get all this paperwork and it says, call Dr. So-and-so for an appointment next Tuesday. Some do, some don't. That's not the way it should have been done. The appointment should have been made before you left the hospital. And then you wouldn't have missed the appointment, gotten sick again, and had to come back in. So the first way I think we can really save big-time money is the coordination of patient care through a really nationwide medical records. This is not a guess. There is one part of American healthcare that does that and does that very successfully, and that's the VA. And the VA is an interesting place because patients who get health care at the VA essentially stay within the system unless there are special circumstances. And they have produced electronic medical records that talk to each other. And the end result is they are providing better care and saving money at the same time. Notice this has nothing to do with end-of-life care. Second way of saving money. We need we need to rationalize payments to all forms of providers. And I have a lot to say about this, about hospitals and doctors, but mindful of where I am at the moment, I'll focus in on the producers of new pharmaceuticals. Because we all just, I know. Okay. So what should we pay for new pharmaceuticals? What's an adequate rate of return for those who invest in research and development so they will continue investing in research and development? That's a question that we have not as a society been willing to address. And that's part of the reason why healthcare costs grow. And one other thing. We introduce a lot of new technologies and keep them going, even though they've never been assessed. So we don't really know if we're getting value for money. And we could save a lot of money there. Again, it's not an end-of-life issue. So to prove that to you, I'll tell you about how we could have saved about $7 or $8 billion a year, and we've only captured half of that saving. A group of us ran a number of years ago a randomized controlled trial for surgical treatment for patients who had osteoarthritis of the knee. This was a procedure that was done all over the country in large numbers. It was actually one of the largest, if you look at the Medicare database, it was one of the largest of the number of procedures done a year. Nobody had ever studied whether it worked or not. And given that it was arthritis, there was no reason to believe that using water to flush out the cavity and sort of filing down all the bony areas would work. But everyone did it. What we showed was that, in fact, it was no better than sham surgery. There was an ethical issue about running this trial. That's how I got involved in it, namely the issue of sham surgery. But anyway, we can come back to that on another occasion. So here we are, spending all this money on a procedure that had actually been shown was no better than pretending. Well, lest you think that was just the VA, who knows what the surgeon was like. A group in Canada ran the same study a few years later, and they got the same result. So now there are 2 randomized controlled trials proving that this surgery is just totally inefficacious. And I'm pleased to report that the percentage of the surgery that has gone down, it's gone down about 40%. That means 60% of the surgeries are continuing to be provided. What a great way to save money. Another anecdote. About a month after that study came out, I was at a party, and one of the other people there was an orthopedic surgeon, and he had obviously had too much to drink. So he came over to me very belligerently and said, "Brody, what do you got against a surgeon making an honest living?" To which my response was, I have nothing against someone who's making an honest living. And he wasn't that drunk that he couldn't understand what I was trying to say. So we have easy ways of saving large amounts of money if we make a short-term investment in technology assessment. Better before we even introduce it, but even if necessary, afterwards. There will be harder cases, and where we may or may not want to save the money. And here's an example of that. This actually is sort of end-of-life care. Patients with advanced prostate cancer are treated basically by castration, sometimes surgically, but usually medically. And at a certain point, it stops working, and they die. And frankly, it's not the nicest death, especially if the cancer has spread to their bones. Well, there is a new drug out called Provenge, and which has been approved by the FDA for treating advanced prostate cancer. The IMPACT trial showed that on the average, it increased survival by 4.1 months. That is about 17 weeks. There are 3 treatments required. They each cost $31,000. So the total cost is $93,000. Lest any of you think that this is just a matter of a drug company gouging people who are desperate. The actual cost, real cost, for developing and testing this drug were over $1 billion. So there were a lot of costs to recover. But remember, I think we need to think about the question about what cost recovery and profit we need to allow drug providers. Okay, that's how it is. So here's the big question. How much money are we willing to spend as a society for 4 months of additional life? Now, if I ask you, if I can keep your symptoms under control, I guess I shouldn't point to any of the women, since it is prostate cancer we're talking. Okay, if I ask you, thank you, I'll pick on you for a minute. How much money should we as a society spend to keep you alive for 4 months? Now, don't shake your head one way or another. If you might not want to spend the money, but you don't mind society spending the money. But we have to ask that question. How much is 4 months of life worth? I don't know how to answer that question. But those are the questions that we need to ask. Okay, so my thesis has been that we as a society and as individual clinicians need to focus less on the economics of end-of-life care. They are not really the source of our problem, nor are finding ways to save some money there, the best way to solve our problem. But there is still something very amiss about end-of-life care, and that's what I want to talk about in the rest of my talk. We need to focus much more on having a discussion about the values that an individual might consider when reflecting upon the issues of end-of-life care. The truth of the matter is, the decision to continue or stop life-extending care is a highly personal decision reflecting different fundamental values, but that does not mean that healthcare providers can't have a dialogue with patients and their families about what are the value issues that are involved. So in the time that remains, I want to talk a little bit about dialoguing with people who are dying, although we can't tell exactly when, about the values relevant to continued end-of-life care. And I want to begin with a quotation now from Walter Kaufman, who used to teach at Princeton when I was a graduate student there, and was very well known in those days as a widespread public intellectual who wrote about a lot of different things. And there are two things in particular in this quotation that I want to emphasize. The first, I'll go to the second paragraph first. Our coach has long made the mistake of going in for a mindless cult of quantity, counting the ever-growing life expectancy as a self-evident success, as if death were the only enemy of man. See, what Kaufman was trying to say, we keep on throwing money, and we do increase life expectancy, but we don't know at what cost to the patients. I do not mean financial cost. But as he tries to say, we have made a mistake, maybe an obsession with the question of how long people live, as opposed to the quality of life of people. And we need to get, not only society, but patients and their families to think about that issue. As he says, death is not the only enemy of man. But there is another part I want to emphasize, and it comes up in the first paragraph. But for those who reach old age, the best insurance against hopelessness is surely to have lived rich lives, to have lived intensely, to you've used our time so well that it would make little sense to feel cheated or to feel that we need a little more time. About 10 years ago, my kidney shut down, totally and unexpectedly, and I needed to go on dialysis, which went on for a while pretty nicely, and then it started to be a disaster. And although no one said it to me to my face, it was eminently clear in their faces that most of my providers thought I was going to die. But then I got a break. There was a window of opportunity, and my son flew in from Israel to donate a kidney, and here I am these many years later. But what I want to tell you about is what I was thinking about when I was facing and confronting the fact that there was a very good chance that I would be dead soon. And I was only 60. And I remembered and asked someone to bring me back the text of the Kaufman's, a very famous essay called Death Without Dread. And I began doing a very strange thing, but I think really a very good thing to have done. I sort of thought back about my life in the first 60 years. Lucky to be married to a wonderful woman, have 3 wonderful children, lovely grandchildren. I've had a great professional life. All types of other good things have happened. So I live already at the age of 60, I thought, a richer and better life than a large number of people. I didn't want to die then, but I didn't feel hopeless because I had all that past to think about. And that's an important thing for patients who are really in the possibility of dying, for us to get them to be thinking about. Death is not the only enemy of man, and if you live life well, there's no reason to feel cheated if you die. Now, I think that Kaufman, I'm just going to make this one more slide and then stop. I'm not going to be able to get through this talk entirely. I think that Kaufman overstates his point. And certainly Minister Asso is just wrong, and we'll forget about Minister Asso for now and maybe forever. Okay. There are actually some reasons, even for people who are feeling that there's a good chance they will die, to say, I don't care how rich of a life I have a reason to try to live a little bit longer. And one reason I've always thought was important, I want to be there for, and you can fill in the rest. The marriage of my daughter, one that I don't have, but someone else might say that. There is a hospital in New York which actually now has a marriage chapel on the roof of their building, built because it was not uncommon that people who were dying said, I want to be there for my child's wedding. And they rushed up a wedding by several weeks or several months so that the person could have that experience. By the way, that hospital has fewer people saying, you got to keep me alive because I want to be there for it, because they've already made it possible for them to be there for it. Okay. There are still things I want to do, or I need to do. And sometimes that's true. So what we need to do is facilitate people doing what it is that they feel they need to do. I still have unfinished business, so I need a little more time. Sometimes that unfinished business is spiritual business. I haven't yet made peace with God. Sometimes interpersonal business. You know, our family has been at odds with each other for years. I got to make peace before I die. This is, I'm afraid, not such an uncommon phenomena. At Bentow, we once kept a dying patient alive for over 36 hours. And there's no point in counting the number of codes because you couldn't tell when one ended and the next began. And the hospital administrator came and says, what in the world are you doing? And here's the story. The man and his son had been estranged for 40 years. We called the son to tell him, your father is dying. And the son said, can you keep him alive long enough so I can get there to say, I'm sorry? And we said, oh, we'll do our best. I didn't even want to figure out how much money we spent in those 36 hours. Why did it take 36 hours? He was a poor man and he was taking a Greyhound bus. What we should have done in retrospect is bought him an airline ticket and saved the hospital tens of thousands of dollars. But the truth of the matter is, it was a good thing that we did. So sometimes a little more time, Kaufman's wrong. It can be very important. And once we recognize that, we can facilitate things and then stop wasting a lot of money. My life's quality is acceptable, so why not go on living for a while? I got a consult from a former Baylor resident who was then on the faculty of Johns Hopkins. And he called me one night and said, we've got this patient, he's a young man about 40, and he's dying from cancer, and it's very bad. Everything is spread everywhere. And he described it to me, his room stinks. And the reason why it does is because all this terrible stuff is coming out of every natural orifice, plus a few that God had forgotten to create. So it was really just terrible. I said, did you talk to the patient? And he said, yes. And here's what the patient said to us. I'm a young man of 40. I know I'm dying. And I know it stinks. But my friends and my family come in every day. And they put up with it. And they are with me. He said, the second I lapse into a stupor, unconsciousness, so I'm no longer aware that they're there, pull off everything and let me die. But on the other hand, I got a few more days of interacting with these people. Maybe if I'm lucky, a few more weeks. And I want that. Kaufman was wrong about that case. There are cases in which it's perfectly legitimate to spend money to extend life, even for a short period of time. And I've tried to give you 4 examples of that. By the way, the end of the Hopkins story was that's exactly what they did. They went into the patient and said, you really want this? We'll do our best. And the patient said, I told you already I really want this. And they did do the best, and the patient lived, the patient remained conscious for another 10, 11 days and lapsed into a coma. And at that point, they did exactly what he asked. They stopped everything, and he died shortly afterwards. So I don't want to exaggerate the truth of Kaufman's remarks, but I still feel they are extremely important. Let me repeat them to you. Our culture has long made the mistake of going in for a mindless cult of quantity, counting the ever-growing life expectancy as a self-evident success, as if death were the only enemy of man. Here's what clinicians can do to help patients in the dying process and to help society as well. Don't look for ways to save some money. That's not the major way. That's not the major issue. Think instead of what we can do to make the dying process better for those patients. And if we do that, we may in fact wind up not really doing good for the patients, but in a funny sort of way, saving money. Because of course, the second that man lapsed into a coma, they pulled off everything. He could have been alive for weeks yet, and we could have spent a lot of money, and that would have been a mistake. But the crucial point was not that the clinicians were looking to save money. They were looking to provide better medical care for this patient. So let me come to the take-home message. A couple of other nice slides, but we're not going to get them. 2 take-home messages. Focus less on the high cost of the dying. Society has made a fetish of thinking that's the problem with growing healthcare expenditures. I hope I've convinced you that that is only a small part of. It's not the problem. But we ought to focus more on discussions in society and with patients and families about the meaning or lack thereof of the remaining time. That's really what healthcare professionals can do in the crisis of dealing with end-of-life care. Thank you all very much for your attention.